Good afternoon, at least here in Ontario. It is afternoon now. Welcome to our series of the Council of Federation webinars. And we are absolutely thrilled to have well over 100 people from all over Canada with us here today. My name is Doris Greenspoon, and I'm the Chief Executive Officer here at the Registered Nurses Association of Ontario. And with me today is Dr. Irma-Jean Bainock, the Director of the International Affairs and Best Practice Guidelines Program, Heather McConnell, Associate Director of the IABPG, and Josephine Moe, who also works with the IABPG program. We are thrilled to provide you with a webinar that is a series of webinars that Irma-Jean Bainock will describe in a few minutes. But before we do that, let me give you a touch of a background on the Council of Federation. The Council of Federation, as you probably know, is the collective of premiers and leaders from all the jurisdictions, all the provinces and territories across the nation. And the Council of Federation in January of 2012 met and launched the Health Innovation Working Group. And within that group, they decided to focus on three specific areas. The first one is the clinical practice guidelines. The second one is health human resources. And the third one is on the area of interprofessional teams and collaborative practice. It is in the clinical practice guidelines area of a working group that RNAO has had the privilege to join with the Canadian Nurses Association and the Canadian Medical Association and HIL in working under the leadership of the ADM of Ontario, Basanti Srinivasan, and the ADM of Alberta, Diane Wilson, in promoting clinical practice guidelines, and more importantly, in selecting clinical practice guidelines that are beneficial for the entire country. And it is within that work that we were honored to have one of our guidelines, the one on prevention and treatment of pressure ulcers for persons with diabetes, selected as one of the two guidelines to be implemented across the nation. So with that, we want to share with you the work that we have done so far in the webinars, as well as the next ones that will come. But before we do that, let me a bit share with you, especially for the many of you that are from other jurisdictions outside of Ontario, a touch about RNAO. RNAO is the professional association speaking out for registered nurses and for the healthy public policy in Ontario. In speaking out for nurses and for health, RNAO is a voluntary association with over 35,000 members and nursing students. We are a tremendously strong voice in the province, and we have a very significant influence in shaping healthy public policy in addition to shaping nursing practice. So the Best Practice Guidelines of RNAO is a program that began in 1998 and that has continued full speed to this day, including the fact that now is not only used in Ontario and in Canada through the Council of Federation, but also used across the international community. I will pass on now to Dr. Irma-Jean Bainock to continue with the presentation, and then our colleague Heather McConnell will continue after that. Thank you very much, and happy Nursing Week to everybody.
Thank you very much, Dr. Greenspoon. It's Irma-Jean Bainock, and again, I echo Doris's comments about wishing you all a happy Nursing Week. I will move ahead with the next slide and just give you a brief update of the webinar series. As Doris mentioned, we have a 6-item series. We have had 2 sessions already in this series, and you can see at the bottom of the slide where these series sessions are archived, and you're welcome to access them at your leisure. The session today is focused on implementation strategies, and we will highlight best practice champions and our champion network. This too will be archived shortly following the session. Remind you that the next 3 implementation series will be held June 3rd, July, and August at dates to be announced. But we will move through all of the aspects of our very unique and successful implementation program. I'll move on just to highlight 2 other presenters. Dr. Grinspan mentioned the RNAO presenters, but we are also very delighted to be joined today by Laura McKenzie, a clinical nurse specialist from McKenzie Health. McKenzie Health is a best practice spotlight designate that was designated in 2012. And also I want to welcome Robert Renton, a clinical educator from Trillium Health Partners. And Robert is from an organization, Trillium, that is a new BPSO organization commencing its work in 2012. And they will, all going well, be designated in 2015. I'll move on just to highlight our agenda. I will be talking about the IABPG, or International Affairs and Best Practice Guidelines Center, and then we'll give a brief overview of the assessment and management of diabetic foot ulcers in people with diabetes. Then I will turn things over to Heather McConnell, who will focus on the champions, which is really the key aspect of this webinar. And we're so delighted that Laura and Robert will provide us with lessons from the field and talk about how champions in their organizations have really led the implementation for their work related to diabetic foot ulcer. We do intend to have about 10 minutes at the end for questions and any comments. As Doris mentioned, our program, International Affairs and Best Practice Guidelines program, has been in existence since 1998-99, and our mandate from the Ministry of Health was to develop, disseminate, and actively support the uptake of evidence-based clinical and healthy work environment guidelines. We also are very focused on evaluating the impact of these guidelines in organizations, and in particular on patient, provider, and health system outcomes. The model you see before you in this slide really identifies our rigorous approach to guideline development, which is the very top circle, and we've certainly discussed this in the past, but you can see the 7-step process that we use, and it's critical to note that we review and revise guidelines and every 5 years. If you move along and look at the other 2 circles, following the arrow, you can see that we pay great attention to deployment and implementation, which is where we have been spending the majority of our webinar series sessions. And then the final circle, or final colored circle, is really focusing on our work related to evaluation, monitoring, and sustainability. So we absolutely believe that developing the guideline is necessary for quality evidence-based practice, but not sufficient. You need a complete implementation strategy and approach to make it happen so that we achieve those outcomes for health professionals, clients, and organizations and systems. I'll move on then. The goals of the BPG program, as we've mentioned in the past, are really very much focused on improving health care. one of the key areas that we have discovered is very important to achieve effectiveness and reduce cost is reducing the variation in care. And that is what evidence-based guidelines enable you to do. In addition, you can see that we're very interested in making sure that knowledge gets transferred into practice and that we convey the knowledge base of healthcare and in particular of nurses in many cases. We also are very interested in assisting with clinical decision-making, identifying the gaps in research, stopping interventions that have little effect or cause harm. And this is an area that all organizations focused on evidence-based practice need to pay much more attention to as we introduce new interventions based on best evidence. We need to very clearly identify what no longer works. And then, of course, as I've already mentioned, when you use evidence-based practice, you absolutely reduce the cost of care. I'll move on now to talk about the assessment and management of foot ulcers for people with diabetes. This guideline, which is now freely downloadable from the website, was developed 6 years ago, I believe, and our second edition was out this March, and we launched it with a webinar here. The guideline development team consists of Laura Teague, an expert in wound care working at St. Michael's Hospital here in Toronto, and the expert panel, Karen Bruton, Patricia Coots, Laurie Goodman, Christine Murphy, Heather Nesbitt, Deirdre O'Sullivan-Drombolis, and Ruth Thompson. You can see the RNAO staff involved, which consists of a number of the nurse managers, as well as myself and Dr. Monique Lloyd, and a number of our project coordinator staff who help us keep the guideline developed, and also our research associates. In addition, we want to always acknowledge the many stakeholders who are involved in reviewing the guideline and providing us with feedback as to how clear, how relevant, and how useful they see the guideline being. I'll move on just to highlight the purpose and scope of this guideline. We wanted to have a guideline that addressed how to both assess and manage people with the established diagnosis of diabetic foot ulcers. And this guideline provides evidence-based recommendations for nurses as well as other members of the interprofessional team, because we do know that caring for patients with diabetic foot ulcers is very much an interprofessional endeavor. Now, we also acknowledge that the patient's preference and the assessment data very clearly needs to be used in planning the care and treatment. And we also acknowledge that while there are many different competencies of nurses and others who care for patients with diabetic foot ulcer, we do need to be aware that the best evidence that we have pulled together shapes the recommendations that when used, we can be much more certain of a successful outcome. Now, the guideline also focuses on people who are greater than 15 years of age and with type 1 and or type 2 diabetes who have, as I mentioned, a diagnosis of diabetic foot ulcer. These are the 4 questions that guided the literature search and systematic review, looking at the most effective methods for assessment of diabetic foot ulcer. Secondly, the most effective interventions to manage foot ulcers and prevent re-ulceration in clients with diabetes. Thirdly, to look at healthcare professional education and training to determine what are the requirements to ensure the provision of effective ulcer care. And then lastly, wanted to look at healthcare organizations and how they can best support and promote optimal assessment and manage of foot ulcers in clients with diabetes. The recommendations then from this guideline total 19. There are a number that focus on interventions and the practice recommendations, as we call it. And they have been broken down into assessment, planning, implementation, and evaluation. 8 in assessment, 4 in planning, 5 in implementation, and 2 in evaluation. There are 2 education recommendations and 3 focused on the organization and policy recommendations. And this focus on organization and policy really helps to support nurses and others in their practice so that all of the recommendations and focus on care for patients with diabetes does not rest solely on their shoulders. We really want to be sure organizations have the right structures, the right resources, the right policies in place to make this happen. And you can see that the guideline is freely downloadable at the RNAO website. I'm now going to turn things over to Heather McConnell, who will really begin the main substance of our session, looking at implementation strategies and highlighting the champions as a key implementation strategy. Heather.
Hello, everyone. Thank you so much for joining us today. It's my absolute pleasure to speak to you regarding our Champions Network. And within the context of what Irma Jeans mentioned earlier around the whole focus on deployment and implementation, you can see from this slide that we have a variety of strategies focusing on the individual level, the organizational level, and the systems level. And certainly within our Best Practice Champions Network, we really see that working with individual nurses and organizations and other healthcare providers to really support evidence-based practice. Our Best Practice Champions Network has been in place since the early part of the time that we started working on guidelines. 2003 was launched, and we really see it as a collective force that influences knowledge transfer and uptake of best practice guidelines. To date, we have over 12,000 champions in a range of sectors, and these champions are actually not only in Ontario, but across the country, focusing on best practice guideline implementation and sustainability. We have champions specifically as well in our long-term care program, our smoking cessation, e-health, and addictions and mental health. So what is a champion? The definition that we're using is individuals who dedicate themselves to supporting, marketing, and driving through an innovation. And certainly you can see that there are a variety of different terms used to describe this type of work, change agents, opinion leaders, etc. And certainly when we were doing our initial work in this area and creating the role of the network, we really did look at a broad range of literature types to really get a better sense of what might work best within our program. And we decided the term champion was the approach that we wanted to take. So why do we need champions? Well, we use champions to disseminate evidence, to assist with knowledge transfer, to promote the uptake of practice change, to share resources and prevent shelfitis. And we use that term to really indicate that it's not good enough just to produce the guidelines and have them sit on a shelf. They need to be in the hands and minds of the nurses and other health professionals that are providing care. So we definitely want to ensure that we prevent shelfitis and also, of course, to sustain change. Once implementation changes have happened, really using the champions to help support that change. So our Champions Network really helps to support and connect with other champions and to plan, develop, and refine implementation approaches. We learn a lot from our champions just as much as our champions learn from our team here. And we really want opportunities to share successes, challenges, and brainstorm solutions to those challenges. We share organizational and specific implementation tools. Champions have been incredibly generous in being able to share resources and tools that they've created to help support change in their organizations in order to support others. And of course, we have multiple resources available to them. So how do we prepare our champions? Well, we have a variety of different resources and approaches that we use to be able to build knowledge and skill in this group. We have our Foundational Learning Institute that's really based on the RNAO Implementation Toolkit that we introduced at our last webinar. and the Institute registration is currently open. It's taking place June 9th to 14th in Collingwood here in Ontario. We have local champions orientation workshops. So we actually have workshops all over the province of Ontario hosted by organizations, and they invite a broad range of participants from across the province to join in these workshops. And again, the content and the delivery of these workshops is really very much based on our implementation toolkit, helping to understand the change process. For those that are part of our Champions Network, we have advanced workshops that focus on leadership and mentorship, and monthly webinars that are really led by champions who want to share their experiences they've had within their organization and practice change opportunities. And of course, we also are always looking for dissemination and spread opportunities, and have had a large number of organizations host champions open houses so that they can share their knowledge and skill with their local community. But what does the research tell us about best practice champions? And I'm delighted to share now some of the results of a study that was conducted by a colleague of ours, Jenny Plow, and a number of her colleagues, focusing on the role of nursing best practice champions in diffusing best practice guidelines, a mixed method study. And this article was actually an award-winning article at the Sigma Theta Tau International Convention in 2011. So what this study found was that there is a number of effective diffusion strategies that champions used. And these included dissemination of information about clinical practice guidelines. They were seen as persuasive practice leaders, and that they were tailoring the guideline implementation strategies to the organizational context. And I'll speak to each one of those individually. The dissemination of information about clinical guidelines. Well, we really found that in the study that the champions were really raising awareness about guidelines through the use of formal and informal educational strategies. And this might have included face-to-face sessions, group education sessions, workshops, presentations, and then of course electronic or video-based learning. They were also seen as a resource to support and mentor other healthcare providers in the change process. They were seen as knowledgeable or experts about the clinical content of the guideline, but also about the implementation process. And they provided leadership about guideline implementation through mentoring and role modeling. Again, they were seen as persuasive practice leaders, working through committees and other organizational structures. And in fact, this was viewed by both champions and administrators as a really successful strategy to facilitate guideline implementation. Champions work with nurses and other health professionals in an interprofessional team to help support guideline uptake and practice. And this was really seen as a very successful strategy to include the entire interprofessional team in guideline implementation. The third area, effective diffusion strategy of champions, is that of tailoring the guideline implementation strategies to the organizational context, and recognizing that the evidence needs to be considered in the context of the organization that you're introducing the practice change to. So certainly this was seen as a really critical role of the champions to be able to translate that information into something meaningful to their colleagues, but also to explore and audit and monitor best practices to improve client care delivery and outcomes, and also to look for unique and innovative ways of developing policies, protocols, standards, and documentation processes that really help to harmonize and unify practice across the organization. So certainly we found in the study that there are a number of factors that contributed to the success of champions. And these included things such as adequate time within their workload to actually focus on practice change and the support of their colleagues, to have formal and informal recognition of the champion's role throughout the organization. Clearly there was a need for support from upper management as well as their team at the team level within their own unit or program, recognizing that they needed to have support from other healthcare professionals and those providing direct patient care. Other areas that were really seen as significant is having specific education and training related to best practice guidelines. So again, really having a clear understanding of what the role was of the champion, the expectations within the organization, and then the education and resources to really help support them in that work. It was clear that those champions that have a specific area of practice or a particular unit or site were most effective rather than champions that were trying to implement practice change across the entire organization. So having a team of people working at the local level with clinicians was seen as really important. Being part of a team or a network of champions, again, which we've mentioned. And then again, champions have strategies to manage staff resistance and create engagement. So certainly recognizing that not everybody may be supportive of the practice change, and really having approaches and ways of dealing with that type of resistance was seen as important to the champion role as well. So impacts of champions and guideline uptake. Well, there are many different impacts that champions have had, but again, really is recognizing that champions use strategies at multiple organizational levels, so that they're clearly working with frontline clinician staff, but also working within the organization to help support policy and documentation approaches. That there's really a clear need to attend to various stakeholder groups, and so that recognizing that there are many, many individuals and staff will be impacted by practice change, and really being able to focus on that and utilize stakeholder engagement strategies was really quite critically important. And again, to tailor diffusion strategies to the organizational context to make it meaningful to colleagues and to recognize the patient population that they're serving. So impact of champions on guideline uptake. So again, they hold multidisciplinary dimensional roles. They can be seen as educators, facilitators, mentors, leaders, policy developers, and evaluators. They're active knowledge disseminators of clinical information to nurses and other healthcare providers. And they work with various disciplines at all types and levels of positions to explain, convince, and help ensure guideline implementation. So really quite unique opportunity for individuals to participate in the champion network. I'm going to turn it now over to Imogen Baynock to introduce our next speaker.
And before I do that, thank you so much, Heather. And I do want to mention a couple of things. One, please be aware that all of the strategies that we speak about, the types of education we're talking about, and even our own institutes, we're looking at working and being available across Canada and indeed around the world. In fact, many of our spotlights that currently are in Quebec, in the US, in Spain, in Australia, are using these strategies with great success. So please be aware that this work is very transferable. I do want to also just say, before I introduce our next speaker, that you may be looking at some questions in your mind like, well, how would we get started? What do we do? And you'll hear that, I think, from both Laura and Robert, but basically you've got some of the groundwork for what is a champion. A number of our organizations send out a call for champions to get that group organized. Some of them tap people on the shoulder who meet that definition, so that we end up with a keen group of leaders, if you will, who will take the guideline from the paper to the hands and heads and hearts of nurses. In addition, the champions are very much a part of our BPSO experience, which also is available to all of you across the country and around the world. And in fact, our next two speakers providing us with lessons from the field are from our BPSO organizations. And I will invite Laura McKenzie, who is a clinical nurse specialist from McKenzie Health, as I mentioned, that became a BPSO designate in 2012, to talk about their way of introducing champions as they implemented some 17, I believe, BPGs in their organization over a 3-year period. So Laura, if you will, please take on the next set of slides.
Thank you, Imogen, and it's a pleasure to be here. As Imogen mentioned, we did actually implement 17 best practice guidelines in the first over 3-year period, and we're in sustainability, but we're also now picking up new recommendations related to a lot of those different guidelines. I can't seem to move the slide. Can you hear me? Hello?
A bit, Laura.
You probably need to speak louder.
Okay. I'm not able to move the slides for some reason.
We can move for her.
Yeah, we'll move the slides, Laura.
Okay. So if we can just move to the next slide, please. Can we move to the next slide? Thank you. So the best practice champions at McKenzie Health were made up of teams, and that was one of the things that had been presented just before by one of the other presenters here, that we were implementing 17 different guidelines, and it was absolutely impossible to have champions for every single guideline. So instead that we took an approach that the champions would be unit-based, and they would comprise of a team that was made up of the educator, the APN, the manager, the champions. We were all one team and champions. And this was, as the best practices came to the particular unit, that was the team that would implement them. So that team, depending on what unit the person was on, would implement stroke and falls and pressure ulcers. So each unit had the team, and that team was the champions that looked after all the different BPG guidelines. If we could just change the slide, please. Okay. So how were they prepared? All of the champions attended the RNAO Best Practice Champion Workshop, and all of them found it extremely beneficial. The KT team members involved in the implementation for asthma and for stroke, they received additional workshops because it was part of a research study. So we had the funding to be able to provide the extra education. But all different champion groups did receive a small workshop depending on what the guideline and recommendation was, anywhere from 1 hour up to 4 hours, up to 8 hours. So depending on how complex it was. Initially, in the first part of it, they would also get not just the guideline, for example, about stroke, but also how to, strategies and how to bring it forward and then disseminate the information. Tools were also developed to help the champions in providing education to their peers. So, and how were they supported? They were provided with, as I said, the tools in order to teach their peers. They also had open door. All of the leads ensured that anytime there was any issues at all, that the champions could come forward and the door was always open. It could be something good. Guess what? This team's doing really well with implementation. It could be, oh, we have a concern. How can we strategize around engaging these particular staff? So that was important. Provided times, like I said, to strategize, and also recognized on the unit by management for their efforts. And that recognition went forward to directors and to the EFT level as well. So it wasn't just a pat on the back by the manager, but it was something that everybody was aware of. Next slide. Thank you. So what was the impact? We could not have done 17 BPGs in the 3-year period without the champions. They were absolutely critical to the success of the implementation of the guidelines. They were the informal leaders in the hospital. They were chosen by their managers and CEs and then by word of mouth, and they had a lot of influence with their peers. And so bringing them on board, they were able to engage their peers in an enthusiastic approach to implementing, and that it wasn't just going to be, oh, something else to do. As well, they were available 24/7, so they were able to provide just-in-time education and support to peers, and it would have been impossible, I think, near impossible to do this without their dedication and commitment.
Thank you very much. Thank you very much, Laura. That was very helpful, and we particularly liked the ending when you said it's impossible to do this work without support from the field in the form of peer leaders, if you will, who can really make a difference for their colleagues and helping them understand the importance of implementing guidelines. I now want to turn over to Robert Renton, and Robert is from Trillium Health Partners, and Trillium is one of our newer spotlights, has been 1 year in the process of implementing multiple guidelines through the BPSO initiative. So Robert, I'll turn things over to you, and we'll see how you make out with managing the slides.
Good afternoon, everyone, and happy Nurses Week to all of you. Trillium Health Centers, as you said, working with the best practice guidelines for about a year now. In the last few months, we've got, I can't do the slides either. I'd like to see the next slide, if I could, please. Thanks. So the champions were a great group of people that I've been very fortunate to work with. Karen Wachowski is our co-lead being that Tri-Site Hospital, Trillium Health Partners is, and our particular site is the Mississauga site. Karen Wachowski has been 30 years as a skin and wound clinical nurse specialist. So we've had great leadership on this team. I mean, who better to help us with diabetic foot ulcers than someone with that type of experience? The champions themselves, again, you can see are all nursing or clinical educators, and they're champions on the inpatient units, making use of their expertise in different, surgical, cardiac, general medicine areas. So a great deal of experience there to call upon again. Next slide. Thanks. The role of the champion, the best practice guideline team was created with champions that display leadership and have the ability to change practice. So again, we've relied on the clinical educators to help get onto the units where they know and work daily with their team, with their clinical leaders, with the change, the people that are more likely to accept change. And we use classic change theory again, just as you'd expect, and just as it was recommended by the best practice guideline to help convince people that this was a useful change. Education days for the champions to review current best practice related to diabetes and foot complications, to practice and strategize our team's approach. And then we did, the champions did attend the RNAO best practice guideline workshop, which again was quite helpful in sort of strategizing and planning our steps towards implementing these changes on the units. The pilot unit was selected as it was known as a unit that would accept change. Lots of people there that were interested in helping us bring this forward. And of course, it was one of the units that one of the clinical educators was responsible for. So that was, again, an easy choice to make. The routine meetings organized to ensure target dates were being met. So we just set up some goals and some objectives for ourselves and dates to meet them. And they had to be a little fluid, of course, because the first unit was the first unit, so it took us time to make some adjustments, but things went reasonably well. Next slide, please. So the goal, as I was talking about, that our goal was all patients with diabetes entering the system will have an assessment of risk, receive education, and a referral for follow-up as needed, and that can take different forms. It could be anything from an inpatient urgent assessment to outpatient referral to their family doc to follow up, or to the Diabetes Education Center. Excluded, it says pediatrics, obstetrics, and psychiatry. Objectives were to create a new assessment tool for diabetic feet, patient education materials, and referral places and process in place for at-risk patients. And the part of the new assessment tool, of course, was to define what is an urgent at-risk patient and what is a patient that will benefit simply from education. Next slide, please. So the role of the champion. We assess staff's learning needs using a pre-implementation assessment questionnaire and posted diabetic foot complication information on the board in the form of this poster, as you can see underneath. Next slide. The diabetic foot assessment tool ended up being about 4 or 5 pages long, so it was an in-depth assessment. Patient education package with community resources, algorithm for assessing risk and prioritizing care, and the do's and don'ts of foot care, a pamphlet to be given to the patients themselves. With doing the assessment, it really is a great opportunity for us, as cliche as this sounds, or almost trite, to convince the nurses to do this. You can say truly that this is life and limb. You are doing something that will allow these people to stay at home, to maintain independence, to truly have an effect or a useful life, rather than being unfortunately limited to a wheelchair for the rest of their days. Next slide, please. So we network with clinical informatics and decision support to create audits and tracking tools. Unit in-services for all staff aimed at diabetic foot complications, provided foot resource tools, how to capture the patients, and charting requirements. So some of the things were new to the staff, such as the monofilament testing to see if the patients had sensation in their feet. And that all came as part of the rollout, being with the nurses, supporting them as they're doing it, and making sure that they're there and if they have any questions. So it certainly took some time from the educators themselves to be on the units, helping one-on-one with the nurses the first time they would do this type of testing. And we get excellent feedback from the staff, and none of this could be done without the incredible staff and support of the bedside nurses and the clinical leads on the floor. They were absolutely instrumental in getting this done. Without buy-in there, I'm sure everyone knows this, but you are shot. Next slide, please. So experience as a champion. The change, of course, is going to be difficult. Everyone's challenged by change, and it takes a while to convince these people. But as I said earlier, when you just sort of use that cliche saying, this is life and limb, we can make a great difference here. I know for me, in years past, if someone had been admitted with an appendectomy, and they had a big bandage on their foot, I think it's possible that people would just say, well, that's not why they're here, not to worry about that now, let's get them through the appendectomy and get them home. Weeks later, they come back in with, a gangrenous foot, so this is a big deal to make sure that this stuff's getting covered. Aware of the barriers, increased acuity and workload, always a concern. So we had to make sure that what we were doing was succinct and clear for the nurses to manage. We're still tweaking it, to say the least, and we're taking the feedback from the frontline staff very serious. Time to implement a new practice and assessment tool was our work, and it was interesting. And we were using the best practice guidelines. As you were introducing or explaining the stuff earlier there, I was thinking, oh yeah, we did that. Useful stuff that came from RNAO for sure. Implement an incremental process that continue to support the staff during the time of change. We're there every day right now, 4 or 5 days a week, making sure that this is getting done. Staff are engaged after they see the value of preventing foot ulcers and complications. Encouraging the staff engaged and involved, provide champions with positive reinforcement, and takes everyone, collaboration of the team, to implement new practices. So again, IT, pharmacy, skin and wounds, the leadership team in the hospital, all were very instrumental in helping us get this done. Next slide, please. And these are just some of the organizational supports, of course, our CEO, executive sponsors, Catherine Hayward Murray and Patty Cochran, best practice spotlight lead, Christina Zettler, professional practice lead, Sharon Gibbons. The pilot unit was to be a surgical unit, a manager and CQC on staff there, of course, critical to this IT decision support. And the impact on patient change. All patients admitted with diabetes are assessed, are being currently assessed for risk factors and foot complications within 24 hours. We are assessing if patients are high or low risk, and we're implementing appropriate resources, and those resources are in place and readily available. All diabetic patients receive education material and community resources. Everyone going home receives a small package with information and tools to assess at home. I think that's it from me.
Thank you very much, Robert. That was very helpful. I do want to just reinforce a couple of points because you can see, those of you listening in, that we went much beyond champions to talk about a number of different factors. So champions alone won't do it. You can see that both of our presenters spoke about identifying those passionate, committed staff, but also providing them with education through the Summer Institute, Champions Workshops, providing them with support, having strategies. Robert mentioned an incremental approach to change. Lori mentioned the bundling of guidelines, offering feedback. Feedback is really what helps staff see the value of this. Reinforcement of the champions as well as of the staff carrying out this work, and recognizing that it does take a team. So from both of our presentations, I think we've gotten some of these tips on guideline implementation. I want to now turn things back to you to see if there are questions or comments. So the floor is open now for questions.
Meanwhile, that people send your questions, and you need to click on the bubble on the top on the left to send questions, I believe. And meanwhile that happens, this is Doris Greenspoon again. I want to invite all of you that want to further this work in your own jurisdictions to connect with us and to explore the possibility of you becoming one of the best practice spotlight organizations. As we said, we have 298 sites across the world, and it will be tremendous if jurisdictions across Canada join in the journey in a structured way. Champions is one of the elements of that structured way, but the same as we need individual nurses committed to implementing evidence-based practice, we also need equally committed healthcare organizations. And what the best way to do that? That's through a formal agreement with the best practice spotlight organizations. And to clarify for you, we do not charge a fee to become a BPSO. We provide the supports and the materials to become a BPSO, so we would be thrilled to provide those same supports to you.
Thank you very much, Doris. I think you can see that if you do have questions, to type them in the chat box. Okay, we have received a question. We're looking at it. Okay, we received our community health center is eligible to be a best practice spotlight organization. The answer is yes, absolutely. We have spotlight organizations from all sectors, nurse practitioner-led clinics. We do have a community health center, a family health team, as well as public health, acute care, long-term care, and home health care.
In fact, just to add spice to the wonderful comments of Dr. Bainock, Thursday, I am visiting the nurse practitioner-led center in Thunder Bay, who is one of our BPSOs, and I'm going with the leader of the opposition party there by their request.
That's great. Thank you, Doris. Are there other questions? Okay, there's a question here. We'll just see the top of it. And the question is, do I just move it up here? Up here, okay. So this is, do you recommend that the initial BPG Champions workshop is delivered in one 8-hour session or split up into smaller sessions? I can certainly have Heather respond to that question, and
Thanks, Imogen. Right now, currently, our orientation foundational workshop for champions is actually a full-day in-person workshop. As I mentioned earlier, we've had the opportunity to facilitate these sessions in multiple places across the province to try and reach as many people as we've been able to. We've also conducted these sessions via OTN, video conferencing technology, to help support those that may not be able to attend an in-person session. So our foundational and our advanced workshops are currently full-day workshops. However, we have had, and have found to be highly successful, webinar sessions that have been much shorter. We do those quarterly. They're usually about an hour and a half to 2 hours in length, focusing on a very specific aspect of the guideline implementation process. So we've done a combination of both, but right now, certainly, we've found that having an in-person full-day meeting, an opportunity to network with others, gain knowledge and understanding of other people's contexts and some of their implementation successes has been very worthwhile for us, and we found it to be quite successful.
Good. Thank you, Heather. I think the other thing to keep in mind is looking at your context and what is possible is really a critical factor too. Are there other questions? Just waiting for any other questions. Okay, I'll just scroll down here. Oh, let's see. Can BPGs be used overseas? Oh, this is a lovely question, and the answer is a resounding yes. We have spotlight organizations who are implementing best practice guidelines, and they are in Spain. We have 8 spotlight organizations. We have 3 in Australia. We have 2 in Chile, 2 in Colombia, 1 in the U.S. It's not overseas, but we do find that many countries have accessed our BPGs on the website and are using them very successfully. Our guidelines have all been translated into Spanish. Many of them are translated into Italian, about 2/3. Of course, they're translated into French. And in addition, we have some guidelines in Mandarin and Japanese. We also are working with Brazil to have all of our guidelines translated into Portuguese. So the guidelines are being translated readily and used very effectively in all sites internationally.
To add to the comments of Irma Jean, and just to clarify for all of you, 2 things. First of all, the translation is done with funding from those countries, a formal request. So in case that you have linkages in other countries, that's why we are sharing. You can ask for formal permission. They will need to pay for the translation. Then they get posted in our website, and they have universal access to anybody that wishes to utilize them. So we don't charge again for that service. The other thing, and this question that you just asked, is very apropos actually of what happens here within Canada. Not all communities in Canada are the same. Not all jurisdictions in Canada are the same. In fact, even within Ontario, not all communities are the same. So the same as the guidelines need to always be contextualized within where we live, play, and work, the same happens if it is within Ontario, within Canada, or internationally.
Now, I noticed there are some colleagues, I believe, from other countries. I didn't know if any of them wish to make a comment. While they may be...
you may want to mention about the ICN meeting.
Okay, I will. Excellent, thank you. So I'm seeing another question. BON has used the foot ulcer BPG to revise our foot care forms for client assessment and caregiving. Can you suggest any practice evaluation strategies? We are still paper-based primarily. One of the things that I would suggest right at the outset is that we have a number of indicators that we've developed based or related to every guideline. And the diabetic foot ulcer does also have an evaluation and monitoring chart. And in the current edition, it is on page 55. And one of the things that we consistently do is focus on structure, process, and outcome indicators, and then are looking at that impact on the organization, on the provider, and on the client. So if you look at that guideline, you can see under the evaluation and monitoring section how you might start looking at some ways of evaluating outcomes for clients by using the very specific indicators provided. Now, I should also mention that you do mention that you are paper-based, but our evaluation mechanism called NQuire, which is Nursing Quality Indicators for Reporting and Evaluation, will enable broader evaluation for all our spotlights related to the guidelines they're implementing. And each of the guidelines have the particular indicators I mentioned, and all our spotlights are able to enter their data using these indicators. And I would also mention to you that our last webinar session for our current series in August will be focusing on both NQuire and order sets. So I hope that does help you with your question. How frequently are the BPGs updated? Our BPGs are reviewed every 5 years, and based on that review, a new edition is put out. So generally, we're putting out a new edition every 5 years. But we're very committed to always having the most current information in our guidelines. Now, if the situation would change drastically and we have evidence that, well, before 5 years there is new information, we absolutely would review and update the guideline. Do other BPSOs set up local champions workshops to help support individual champions and provide a forum for champions to network, problem solve, share success, etc.? I may just turn things over very quickly to Robert or Laura to mention what their BPSOs have done.
Hi, it's Laura. We, at McKenzie Health, we actually did have some days where once a year we would set up in the auditorium posters with some of the champions there talking about what they've done on their unit with a particular BPG. And it was an opportunity for them to share and recognize each other and strategize from each other.
We certainly, yes, got word out using this a similar form of communications, meeting with groups, getting the buy-in from the units, doing that type of advertising, if you will, to make sure that people are aware of what's going on. There's six best practice guidelines we've chosen for our organization at present. As we said, they're still relatively new at Trillium Health Partners, so some of these things are still a work in progress.
Okay, thank you very much, both Laura and Robert. I do want to move us to the last slide and wrap up our session. This has been absolutely fantastic. As your closing, or as we're closing, I want to remind you of 3 different items in particular. One that isn't on the slide is at ICN, which is coming up in Melbourne, Australia. RNAO will be having a special BPSO session on May 23rd from 9 until 1 p.m. Many of our international BPSOs will be there, as will those from Canada and other countries who are interested in being a BPSO. Watch for our website. We will send out very specific information to all of you who have attended our webinars. I do want to also mention to you that our next event that you may be interested in related to BPGs and champions will be held on June the 9th to the 14th, our BPG Foundational Learning Institute. It's a great getting started strategy for champions in your organizations. I want to invite you to our next webinar, June 3rd from 12 to 1, which will focus on BPSOs and becoming